Thank you so much for the kind introduction. All right. After such a bombastic lecture from Dr. Jatin Shah sir, whose photography I truly admire, apart from his being such a veteran in IVF, I think this topic is going to be a bit of a bit of ice cold water, but that's okay because the topic that we are going to talk about is reproductive genetics. And even today in clinical practice, we are just skimming at the tip of the iceberg. I mean, it's such a vast topic that to cover it in 20 minutes is pretty hard, but I'm going to try to just give an overview. This is the scope. We're just going to talk about what's the scope of reproductive genetics right now, how the laboratory science, genetic as well as embryology is connected to clinical practice, not just IVF practice, but also OBGYN. And what is the role of OBGYN? This will be basically an ongoing point in the whole presentation. All right, so we begin with the preconception workup. So reproductive genetics before conceiving is where we see our couples and our patients is most of the reasons that we see patients are infertility. So here we are basically trying to screen the individual or the couple before conception. And the one thing that is extremely easily available to clinicians and highly underutilized in the Indian context is the humble karyotype. Karyotyping is a test, a genetic test that can be done for any individual or the couple, can be easily provided by obstetricians and gynecologists before conception. The person doesn't even have to go to a fertility specialist. If that person is going to a gynecologist, they can simply be offered something called a karyotype. And this is something that we are trying to do as awareness to just tell gynecologists to increase the number of patients they send for karyotyping. The other thing is carrier testing. Now, this is something in context of treating patients for infertility. This is mainly done when the patient comes with you and they have a certain disorder that are looking for, or they have a particular history of not conceiving or having genetic disorders in the family. So this is carrier testing. Basically, it's a gene array that the genetic lab provides to you. In India, now there are multiple laboratories that are providing gene arrays. Around 5,000 genes are being screened, over 500 disorders, but we need to understand that we need to screen them ethnically. So dependent on what kind of disorders are the most common for that ethnic population or that genetic endogenous population needs to be offered to them. So what's the other thing? Sex-based testing. All right, so it should be offered unbiased. I'm talking here because since this is the RCOG conference and we generally speak in conferences that are related to fertility, I just wanted to make this a point, and we make it a point to talk about in our public awareness channel on YouTube and Instagram, Talk About It India. We talk about how intersex populations or people from the transgender populations are coming to gynecologists, have been coming for years, but I think it is time now, if they require some kind of reproductive genetic testing, they're trying to become single parents, I think we should be offering it to them. And if we do have people from this background, we should make sure that they are getting psychological counseling for the same. So just throwing this information out there, that if you do interact with people who are from the background of the third gender or who are intersex and are looking for information about reproduction and information going ahead about how to be parents, then definitely a counselor, genetic as well as psychological, should be a part of the team. All right, coming to the core basics, I see a lot of IVF specialists in the crowd, lot of IVF specialists. So less gynecologists, more fertility specialists here. So I think it would be a moot point, but most people here know about male genetic testing. Now I've added sperm DNA fragmentation into this. It's not exactly a single gene test, but we are evaluating DNA, or what you see as the separation of the DNA from the particular cell. So it does come under the genetic test. So sperm DA5 would be considered something like a screening test compared to others that are looking specifically at disorders. Why microdeletions? This gets a special mention, especially from the Indian context, because before 2018, we were doing Y chromosome microdeletions using tests from US or from the European continent. Today, we have a test that is designed by ICMR specifically for the deletions that are found in the Indian population. So whenever you're sending a patient for Y chromosome microdeletion, please check with your genetic provider whether they are using the test that ICMR has designed for the Indian population, because they have tested this on more than 1,000 Indian male patients. Now, Klinefelter syndrome, whenever you see this patient, it is not very evident that this patient has Klinefelter syndrome, but definitely these patients are the ones that are coming to you with extremely severe oligospermia or complete azoospermia. Jacobs syndrome show a similar clinical background. Now, counseling is warranted not just because these patients are infertile or subfertile and they have a lower chance of pregnancy, but also because there is a greater morbidity and lower life expectancy to this patient. So these patients should not get referral only for infertility. These people should be getting a reference to the cancer specialist. They should be getting a reference to go and talk to the genetic counselor for their overall health and the health of their family in the future. So family tree, how many specialists, I'm sorry, I'm just going to make it interactive because as you can see, there's been too much of a break from coffee. And I just want to ask how many specialists. I'm just a reproductive health researcher, so I just want to know how many people actually have seen family tree mapping that a genetic counselor does for a couple during infertility. All right, so Dr. Gauri, yes, another person. So basically what they are doing is they're creating a tree of all the relatives in and around the patient to see what kind of history they have. If, for example, if they're looking at the tree and there is a particular single gene disorder, for example, there's sickle cell anemia, there's sickle cell disorder in that particular patient, or they have a previous child with sickle cell disorder, then they are looking particularly in the family tree of whether cousins have it, whether it's the direct family or whether it's associated family, just to evaluate what the carrier status could be. And this is also relevant and also important because if you're sending a patient for genetic analysis or maybe doing PGT for that patient ahead, you need the samples of relatives for haplotyping purposes and linkage analysis. A lot of blank faces. All right. Okay. All right. So for female genetic testing, for primary ovarian insufficiency testing, as you can see, X chromosome structural aberrations are increasing in diagnosis. There is something called the Fragile X Syndrome Society in Mumbai. Have any of you worked with them before? The Fragile X Syndrome Society? You must have heard of them, right? Because they are doing very good work in terms of improving awareness that there are so many women with Fragile X pre-mutations who do not know that they have Fragile X pre-mutations, and they have so many CGG repeats that they probably would end up with no oocytes by the age of 30 or 32. And these women have no idea that they are going to require a donor egg conception, which now is so difficult, right? How many hands are raised up? Can I have a raise of hands of people who are being affected by the new law? I think everybody, yeah. So yeah, everybody. That's what I'm just trying to improve. What do you say when the teacher is like, "Dikh raha hai kya board pe? Can you hear me? Can you understand?" So I'm just trying to make it interactive. Just trying to understand. Just trying to tell you that maybe this is time to increase awareness for these things for the basic populace, because there are people who with genetic disorders that require our help from a much younger age. And Fragile X testing is very easily available. It just requires that gynecologists start testing girls and adolescents very early, even if they start seeing even a single symptom for the sake. Now next, identification of genetic diseases. Now here we are talking about pre-implantation genetic testing, and this is something that I can talk on some authority on because I have been doing PGT, PGTM and SR for about a decade or more. New definitions for PGT are, before it used to be called PGD or PGS. Now it's called PGTA, and it's divided into aneuploidy testing, monogenic disorder testing, and structural rearrangement testing. Now, monogenic disorders is a single gene is affected, and you know what gene is affected, and you know what is the disease presentation for this particular patient or for their family. The other is structural rearrangement, that basically is Robertsonian translocations or reciprocal translocations. In these cases, there is subfertility involved. There is also a requirement of doing aneuploidy testing along with structural rearrangement testing in many cases. And it requires personalized test preparation. It takes about a month before you can do this test for the patient. These indications are non-exhaustive, and these indications, I think, are under review by our government, what you can and what you cannot do for the patients in terms of indications, sending patients for aneuploidy testing. All right, this is the general workflow. You do the biopsy, you cryopreserve the embryos, day 5 or day 6 in most cases. You send them for genetic evaluation in your lab of choice. The amplification happens with various different genetic tools. The tool that is currently used is next-gen sequencing. That's all you need to remember. So no matter how perfect PGT technology becomes, before you even think of putting PGT in your particular laboratory, make sure that you maximize your blastocyst rates. Your KPIs need to be A-OK. If you have time lapse, if you have AI, in addition to that, if you are lucky enough to have that, then definitely utilize it. 98% plus recovery and survival is required in vitrification program, and you need certified skilled embryologists that are doing biopsy. And the reason for that is make sure if you're training your embryologists, make sure they go to a place like EmbryoTools Spain or get trained by somebody senior, because what we have seen is the learning curve for biopsies is quite high. So when vitrification came in our practice, I was there. In 2010, when I was in India, we were all doing slow freezing. And when we shifted, very few people were doing vitrification. When we shifted around 2012, at that time, there was a huge gap in learning because embryologists weren't trained. And when embryologists are not trained, your results are shit. Your results suffer. So basically, if you want to start biopsies or you want to start doing PGT, make sure that you get trained with the right team or the right group, or you send your embryologist to the right place, get the right amount of training, and once they have handled 100 animal embryos, then let them touch a human embryo. Do not let them train on your patients, please. Our patients are not guinea pigs, you know, they're human beings. And you need a genetic method that is validated. So do not immediately go for the genetic lab that's giving you the lowest rates. Trust me, 1 to 2,000 rupees per embryo is not going to make a huge difference if you get insufficient data as a result. Okay, so make sure that the genetic labs you use are perfect. What is the third reason why we use reproductive genetics? We want to optimize what we are doing, right? We are doing ART. We do not want to continue doing ART the way we were doing in slow freezing times. We want to improve. And also we want to offer some respite to patients who have not been able to take PGT but want to take prenatal testing. So this is something that you guys are already experts at. I'm just making a note of this. CVS as well as amniocentesis is done for prenatal testing. NIPT is something that still is, there is a huge debate going on in terms of whether NIPT should be replacing amnio. But you should know, cell-free DNA validation in any reproductive genetic, as a reproductive genetic tool is still fraught. Even non-invasive chromosomal screening as well as non-invasive prenatal testing, everything contains cell-free DNA. And cell-free DNA validation is always going to be a problem versus the actual cells from the fetus or the particular sample. So voluntary uptake is increasing, but there is definitely a requirement to validate it with amniocentesis or CVS. What other things are being done in reproductive genetics that are currently under research? Now this slide is always my favorite slide because what's happening next is what we are interested in. Mitoscore is something that you do get with some PGT reports, but mitoscore is again something that is highly debated and it is not always correlating to increased implantation rates. Genetic testing for adult onset diseases like breast cancer by BRCA, this is something that is not allowed widely in India, and if we do require, I just need 30 seconds. If we do require testing for adult onset diseases, then we require a case by case permission from ICMR. And PGTA with artificial intelligence is a tool that is coming in play. There are a couple of companies that are doing it internationally. There was one of them, I am working with them since 2019, pre-COVID. So basically, we are testing PGT with AI and looking whether it's going to improve the live birth. So the outcome is live birth, and it's a very long road from here, probably 4 to 5 years from now. All right, thank you for your attention. I love debates, so you can ask any question you want. Thank you.
Any question from the audience?
Yeah, hi. Thank you for that question. So yeah, so PGTP is basically polygenic risk scoring, and polygenic risk scoring has had so much Twitter fire recently. Have you been on Twitter talking about polygenic? All right. Okay. So in the last S-ray, after polygenic scoring came out, there was one company that came out with polygenic. You must have heard of Natera in US. All right. So they started talking about polygenic scoring, and all the scientists started revolting against them. And the main reason is, even today, when we are doing single gene disorder testing, there is still an error rate of 1.7%. With polygenic risk scoring, we do not even know whether the risk score is correlated to adult onset disease. So it's basically an enterprise in, they are coming up with the assumptions based on previous trials, but they don't have trials on human beings. In terms of, they do not know whether that polygenic risk score is going to end up with a disease. So what they're saying is, until we have long-term data from our health labs, basically the university labs that are looking for children that are born, newborn children, then growing till 21, and seeing whether polygenic risk scoring of their fetal blood is leading to adult onset disease, you cannot be talking about PGTP. However, PGTP is already out in the market. It's already a commercial product. So if you do think that PGTP will be coming in the future, the kind of long-term follow-up that will be required for these cases will be quite intense, and there will be there will be a lot of international pressure, because even today, it's come out in US, but in Europe they are still not very okay, because PGTP bioinformatically and biostatistically is still not validated. Yeah.
What is the role of PGTA in the scenario of the current ART doctors? In case of recurrent implantation failure, it's not actually recommended. So
yeah, I know Kraft does a lot of work on PGT. I know, and we have been working with the Bloom Group also. So the insight that I have is, I would have really loved if Deepak was here, Dr. Deepak Modi was here. The insight, I wouldn't say insight, but what I can say is they have been very hasty in terms of saying that aneuploidy is out of picture. And the reason for that is, if you're saying recurrent implantation is not a... No. The law. Nobody is a proponent. I think it's just the fact that we want the choice of offering it alongside other things. So see, PGTA by itself, right, is still a debate. But PGTA is utilized a lot with AI. It's utilized a lot in the future. There is scope in the future of improving screening of embryos, and it's a screening tool. It will never be a selection tool. It will always be a screening tool. So we have been using screening within our laboratories. PGT is no different. All right. Oh, okay.
hi everyone, we're starting with the MRCO